Oh, okay. Why don't we start here? So we're just getting to distal radial fractures. Yeah, everybody could mute their microphone if they're not talking. Look at the distal radius and kind of divide them into normal, Colles fracture, where you have dorsal displacement of the distal fragment. Usually it's also some dorsal impaction. Smith, which is volar displacement, a Barton's, and it can either be dorsal or volar, which are anterior oblique fractures rather than transverse fractures, and the lunate usually translates with the fracture fragment. So these are the ones, and obviously the interarticular ones are kind of a worse prognosis than those that are non-articular. Okay, so Jennifer, what do you think of this one?
All right. So it looks like we have a predominantly transverse fracture of the distal radius with surrounding marrow edema. I don't see any definite intra-articular extension along the radiocarpal joint, although there is extension to the DRUJ, and there is some tilt of the lunate.
So what's a normal volar tilt?
I believe if you look at the scapholunate angle, it should be.
Talking about a fracture of the if you draw a line along the long axis of the radius up to the mid portion of the articular surface, and then if you draw a line that connects the posterior distal aspect and the volar distal aspects right in the midline, then you'll get an angle here. And the normal person, that angle is about 15 degrees with volar angulation. And that's a good way of stabilizing the wrist. Typically with distal fractures, you land on an outstretched arm, and so your forces are going to be proximally and dorsally, and you'll get impaction of the dorsal part of the radius, and you'll end up with, instead of volar angulation, you'll get a dorsal angulation. And this, most of the time, you're going to have a fracture like this. If you get displacement, which we do not have here, it'll be more dorsal. But this would be in the area of what we'd call a Colles fracture. And typically, you can take, it depends upon the surgeon and so forth, but you can accept up to kind of like 10 degrees of negative retroversion without necessarily the need to go in and do surgery. And these have pretty good prognoses. John, do you want to comment further on the Colles fractures?
Colles fractures do well without any kind of treatment most of the time. There was a study done, in the 1960s, I think it was. They took 100 people off the street.
Fractured all of them.
In Detroit, and checked their wrists. These were people that we see nowadays in the thousands. In those days, it was like in a couple hundred. And X-rayed them and found a lot of Colles fractures in these individuals, but their function was excellent. So most of the time when we try to reduce these are in females, and we try to get the wrist to look more normal rather than try to improve the function, because the function will be good anyway. Now that's totally different from the other fractures we're talking about. Is this an adult, John?
Yes.
What is that line that is going up dorsally in this?
This line?
Yes.
Yeah. This line is just compressed trabecula, and that's not an injury pattern. This would be the underlying bone.
Okay, and lunate looks tilted to me.
Yes, this is an older individual, and they have a little bit of DC, instability of the wrist.
Yeah, okay, that's what I figured.
Yeah.
And the Colles fracture is a little, isn't that a little distal than usual?
It's variable, but yeah, maybe a little, but not much. This is
Yeah.
not a bad place for Colles.
Yeah, this doesn't need any treatment other than for the lunate. I'm not sure what I would do with that. It's probably, like you said, chronic, and I'd just leave it alone.
Exactly. Right. Yep. I agree with you. Michael, what do you think of this one?
I would put, the treatment for this would be a cast for 4 to 6 weeks.
Okay. Michael.
Looks like there's a minimally displaced radial styloid fracture.
Right here. So this is the other ones we just described, but here we can see a little displaced radial styloid fracture.
And we don't see, I don't know if there's any other fracture.
I think this was the only one. You always have to look. Sometimes these will be in association with ulnar styloid fractures as well. John, do you want to comment on a styloid, radial styloid fractures?
Here again, the treatment is a cast, and that will usually heal. Sometimes some orthopods will not treat these at all. I don't know why that is, because this can be a bit unstable.
Okay.
So I would treat it with a cast, and I don't think I would put a pin in it.
Okay.
Some individuals put a pin in it. It's up to the individual, I guess.
Yeah, most of these I've seen have been treated just like you say, with conservative.
Yeah, they either heal or they leave an ossicle there. I'm sure you're going to be showing us ossicles in this area, and that's from old fractures that never healed. Not everybody with a distal radial styloid fracture will go to a doctor, and so they forget their injuries.
All right, so I'm just looking at the distal radius here. It looks a little bit irregular along the volar aspect right there. Is there a fracture going through that volar aspect? Maybe.
I think there might have been an old injury.
Old injury there, okay.
This is just soft tissue. This is just fat in the soft tissue.
That's right, yeah.
So this was on 8/20/07. The patient came back with a fall on an outstretched arm a year later, and this is.
Okay, so now we see it looks like a fracture. It's an intra-articular fracture. It extends through the dorsal aspect of the distal radius. It's obliquely oriented, more transverse. It's a Barton fracture.
Is this rheumatoid, John?
I think this was a patient who had rheumatoid arthritis, yes.
Yeah, this is not a normal wrist, obviously.
Yeah. But
and you're right, that's a Barton's fracture.
Yeah, which we can see right here. I can remember I didn't actually miss one of these when I was a resident, but I didn't describe it properly to a hand surgeon who he and I were very good friends. I rotated a little bit through his office, and he was very disappointed at me. And he called me back the next day and said that I missed a Barton's fracture, so I'll never forget this particular fracture. Yeah.
Well, these you have to treat a little different from others. So
Exactly.
you want to you want to get rid of that gap that you see there.
It was in the emergency room. So he called the patient, said the patient could go home and see him in his office. So he went home, came in his office the next day, and he was very upset because he would have wanted to treat this immediately and not have waited an extra day at that particular time. So
Well, I don't think a day for this would make any difference at all, John.
yeah, he
I
was
think he balled you out for no reason.
well, but he had told the patient didn't need surgery. And so they came back in his office, and all of a sudden he was telling the patient that they did need surgery. So it made him look a little foolish in front of his patient.
Well, he could have attempted to reduce it and tried to do without surgery.
Yeah, well, this was in the pre-MR days. We didn't have MR in those days.
Yeah, I understand. Besides that, as a rheumatoid arthritic, I'm not sure I would do surgery.
Okay, so this is a comminuted impacted fracture of the distal radius. On just these two slices, I don't see any definite intra-articular extension. Okay, so now we have a sagittal image that does show there's intra-articular extension along the central aspect of the radius. There's probably 1 or 2 millimeters intra-articular gap, and yeah, there's some volar dorsal displacement, another Barton's fracture. Okay. So
Is there a volar component there, John?
Yes.
Now this is a little more than a Barton's fracture. This would have needs a reduction and a couple of screws.
Yeah, this is both a volar and a dorsal Barton's together kind of thing.
Yeah, so you can't. This is a little more than just Barton's.
Yeah, this is.
called a Barton because of the way it's displaced.
Well, I think Johns would say this isn't a Barton's, but a Barton's fracture is a fracture that typically is either the one of these alone would be a Barton's fracture. A Barton's fracture, its characteristic thing is it goes into the joint space. In this particular case, we have much more of a comminuted fracture involving both volar and distal, so it's really both a volar and a dorsal Barton's fracture, and the combination makes it very unstable because you don't have any stable component of bone going up to it.
This you cannot treat with a cast. This one needs reduction and fixation because it's going to get worse with time.
Okay, Michael.
Okay, so I see a transverse predominant fracture through the distal radius, which appears to extend towards the distal radial ulnar joint. I'm not sure if it extends intra-articular into the like the radioscaphoid or radiocarpal joint. Now in the sagittal image, I can see that this does extend intra-articularly, and there's cortical step off and mild displacement. And this is kind of posterior. So is this just another like intra-articular kind of comminuted Barton's fracture?
Yeah, well, this is a comminuted distal radial intra-articular fracture. I wouldn't even use the term Barton on this one because you can see that there's a little comminuted fragment right here, and they're kind of multiple fragments. And
Yeah, exactly.
Bone
I actually don't like those words too much.
Which words?
Barton's, etc.
Okay.
I just like to describe the fracture.
Yeah. Agree.
So looking at this looks like changes of ulnar abutment with positive ulnar variance and cystic changes in marrow edema of the ulnar aspect of the proximal lunate. I don't know if there's also edema of the trapezoid, or yeah, that looks like significant edema of the trapezoid.
I kind of point this out is to remember if you see, you always have to look at all the bones, I guess, because often people will see the the ulnar impaction here, or the lunate impaction, and then they'll forget to look at everything else. So this was actually the significant lesion in this particular patient. The other one was chronic.
It looks like there's a vertically oriented fracture there. I can't tell if we're at the level of the trapezoid again. But you can see it's non-displaced and there's surrounding edema, so there is an acute fracture.
With cross-sectional imaging, the bones can be confusing in the wrist because there's so many of them. And some of these fractures, especially if they're in one of the sagittal or coronal planes or axial planes, can be a little bit misleading. So you just have to be careful because any of the bones in the wrist can be fractured with trauma. Okay, Michael? So this guy was actually leading the major leagues in August in terms of the batting leader for Major League Baseball at this time.
It says MLB batting leader with acute wrist pain after checking swing. Well, the first thing I noticed is like a hook of the hamate fracture, but there's a lot of sclerosis around it, so I'm not sure if that's just like a red herring, like because with all that sclerosis, that can't really be acute.
Okay.
And it looks incomplete, like that looks like an old partially healed fracture. So I don't know. What I'm seeing in the other carpals is just volume average, correct?
Yeah.
Like or slice selection.
Right.
I'm not really. Okay, so I don't know if this. Okay, so MRI. This is flipped in orientation, right?
Right.
Yeah, so then the hamate, we do see a lot of edema, but we also see sclerosis. So acute on, I guess it's acute on chronic?
Yeah.
Like an old fracture?
So he had an old
Re-injured or something?
So he had an old healed fracture of the hook of the hamate, and the hook of the hamate is a common injury in baseball players primarily because of batting injuries. And but here we can see that he re-injured it, but now he has a diffuse edema pattern throughout the bone, though the partially healed fracture is still healed. So we were able to tell him that there's a lot of trabecular bone injury. We know it hurts, but this should heal fairly rapidly. And I think he only missed about 3 games. I think he was back playing within a week. That was at a time when the Angels, everyone in their lineup except for one person was batting 300 or higher. We haven't seen that in recent years. Okay.
And that hamate has been stressed quite a few times, hasn't it, John?
It certainly has. That is correct.
So we're looking at a 19-year-old man with left wrist pain following batting practice. There's a lot of trabecular injury of the hamate, especially distally. I'd like to see a few more sequence. It looks like there's a fracture of the hamate hook and significant edema there. So
you're dealing with baseball players, and you can injure it by getting hit by a ball there. But by far the most common is they have an awkward swing, or another one is that they get frustrated, so they hit the ground with the bat. Those kinds of things can then put a lot of pressure on the hook of the hamate and cause these hook of the hamate fractures.
Okay, so here it looks like there's a comminuted and mildly displaced fracture of the hamate, and there is an extension to the MCP joint.
With rheumatoid arthritis and with osteoporosis, and got this one. Michael?
So I'm seeing a lot of kind of signal and cortical regularity, and also involving the hamate on this one, right? Or yeah, right there. So I'm wondering if there's a kind of a vertical fracture through the hamate.
Yeah, this is again at the base of the hook, primarily
Yeah.
in the coronal plane. And this is another osteoporotic older lady.
Yeah, because on that sagittal image, it looks like it's pretty corticated.
Okay, so this looks like a pisiform triquetral joint effusion.
And, it's amazing how frequently, and it's actually good to look at these in the sagittal plane because then you can clearly see that it involves that joint space. But I've seen these called all kinds of things on MR reports because a lot of radiologists don't seem to be that aware of this particular joint space. But it's probably the most frequent fluid collection that I see in the wrists. So, and it's pretty common to see an effusion in that joint space.
So here it looks like there's maybe some marrow edema in the pisiform. There's also some increased fluid signal intensity surrounding that tendon sheath. I can't tell exactly where we are, but
yeah, this is probably the tension, and this is probably just flow effect in the vessel. So yeah, this is edema in the pisiform, and this was someone who the doctor called back and said, the patient really hurts him. Is very tender overlying the pisiform. This was originally not picked up in looking at the images because the sagittal images were positive, but it's just this is a little bone that a lot of people just forget about, but it can be damaged, and so this is just this was just not recognized when people were looking at the images, the edema here in the pisiform. So you don't do anything about this, you don't treat it, but it's a cause of the patient's symptoms. So you don't want to miss it even if it's not going to change treatment. Because often with the patient...
Well, you treat it, but conservatively.
Right, yeah. Okay, Michael?
Okay, so there's quite a bit of marrow edema involving the pisiform, and I believe I can see some kind of hypointense, serpiginous lines. I'm wondering if there's actual fracture and trabecular bone injury of the pisiform with surrounding edema.
Right. Yeah. Okay, so looking at the pisiform, the joint space should be less than 4 millimeters on plain radiographs. It's often angled like we see here. So there's a big flexor tendon that comes around here and attaches, which we're going to talk about in great detail later in the lectures. And it's not uncommon for pull from that flexor carpi radiologist to cause the distal end to widen a little bit more than the proximal end here. You like to see it uniform but not displaced like this. But any angulation less than 20 degrees is thought to be within normal limits. So that's the angle number that you can use. And then it's often a little bit proximally displaced with respect to the triquetrum, but typically it should not be displaced approximately more than 15%. If this is greater than 20%, this is more than 15%, then you have to look very carefully at a tear in the overlying tendon, which we're going to be talking about in greater detail. So let's go on to the scaphoid. That's the scary injury of the wrist and one of the most common ones. People have divided the scaphoid into different areas looking for correlation with injury patterns. But basically what we're going to talk about are waist fractures and proximal pole fractures. So this is the articular eminence of the scaphoid, the tuberosity, the distal part of the scaphoid, the waist, the proximal part of the scaphoid when you're talking about it. But typically, I don't get too involved in using that terminology.
So on the single coronal image, we see some irregularity along the radial mid-surface of the scaphoid waist. Looks like it's fractured and extends superiorly. So
this is a trabecular bone injury. Notice the cortical bone here, at least on the dorsal volar and ulnar margins, is still intact. So this is typically a stable type lesion. It's a trabecular bone injury. It can be a cause of the symptoms. You want to protect it because you don't want them to complete an incomplete fracture into a complete fracture, but this should heal fine without having to have surgery. It was very difficult, if not impossible, to make this decision, this kind of a diagnosis before MR came around, because X-ray based technologies are not good at seeing this. It's primarily the bone edema that's really helping us here.
Okay, so 19-year-old with wrist injury, October 1st, rule out scaphoid fracture. And there is transverse decreased T1 signal with surrounding marrow edema within that proximal pole of the scaphoid. So I think this is concerning for a non-displaced fracture. And there's also some edema in the triquetrum. From what I can see, it's probably just acute trabecular injury. I don't see any definite fracture.
A little bit of injury pattern to the lunate as well. But this would be a greater arc injury, like we talked about before. And but there's a special concern about proximal pole injuries like this. Okay, so this, right, that's 11, that's 10.
This needs treatment. This is not leave alone injury.
Wait a second, I'm just, okay, I'm sorry. Okay.
This injury right here, you have to cast and hope for the best. What I usually did with these is put the patient at cast, including the thumb, because you want to get as much immobilization as you can, and then in a couple of weeks re-X-ray, and again re-X-ray a couple of weeks again, because you don't want these to displace, because once you get a displacement, these are very difficult to heal. If this was displaced, this would need surgery. The circulation in this area is really bad news.
So this is a follow-up on that particular patient. See, this was 10/17/08, and now this is 12/17/08, so we're like 2 months later.
It seems like some of the fracture margin is corticated. I don't see any osseous bridging on that one image. And then on this image, there is edema within that proximal scaphoid, so that concerns me that it may not have enough perfusion.
One of the reasons why you get MRs on these is you would be more concerned if there was no edema. If there's edema, it probably means that it's being vascularized and has a better prognosis. If there was no edema there, then you'd be very worried. And the reason is that the primary vessels for the scaphoid enter through the waist, but they also have some that go distally as well. But there are no primary major vessels extending into the scaphoid proximally. So if you have a waist fracture, it's a proximal pole fracture. It commonly cuts off the vascular supply to the proximal pole and could lead to avascular necrosis. If you follow them and you see an edema pattern like this, that's presumptive evidence that it's revascularizing and therefore has a better prognosis for healing.
And this is good news for the patient.
Yeah. Michael.
Okay, so 23-year-old male with pain and swelling, negative plain films 5 days prior. So it looks like just there's a transverse scaphoid waist fracture with significant surrounding joint effusion.
Okay, anything else you want to comment on?
I mean, the scapholunate ligament looks a little bright, but I think it's intact, the membranous portion.
So we're in the coronal plane, typical coronal plane. Now, one thing to remember is that the exact appearance of the bones in the wrist are going to depend very much upon the positioning of the patient. So if you have any degree of rotation, flexion,
Yeah.
deviation, so forth, you can adjust things a lot. So back when I used to be at the center, I had a plastic wrist a splint, and we'd put all the patients in that wrist splint. It didn't cause any MR problems, but it meant that every time we scanned someone, the wrist was in the exact same position. So I kind of recommend that, and it puts it in a neutral position. You just have to be able to make sure that you do that with the coil so that you can be pronated, as we talked about before. Now, if you look at the scaphoid here, look at the length of the scaphoid here, and
It
look
looks,
at the scaphoid there.
yeah, so if it's not abnormal positioning, the distal fragment is probably, it's rotated. It's probably flexed.
Okay, so what then happens is with these waist fractures are a big problem because there's a lot of stresses along the waist, and we'll explain why that is the case in a little bit here. And what can happen is that the distal end of the scaphoid can flex forward, which is what we're actually seeing here. What happens is that this distal end of the scaphoid should be up here. That's holding the wrist back, making it stable. But if you get a fracture here, what will happen is that the distal pole will flex forward like that. It will no longer hold the wrist up, and we'll talk about the mechanism, what happens. And then if it heals in this position, it's healed into a position where you're going to get a DC, dorsal intercalated segmental instability pattern, and you can get chronic wrist pain. So most surgeons that I know with any sort of a waist fracture will go in and put in what's called a Herbert screw or something like that to make sure it stays stable so you don't get flexion of the distal scaphoid and go into chronic pain syndromes. So many people with these waist fractures have a very low tolerance for it without going in and doing internal fixation. John?
Yeah, Herbert screw is good, but this almost looks like it may need a Rusi procedure, add a little bone to it. I'm not sure that the screw would take care of the problem here. The Herbert screw, what it does, it fixates the fracture and also compresses it. If you compress this, then it even gets smaller in size, and I'm not sure that'd be a good idea.
Yeah, the Herbert screw is for a non-displaced scaphoid waist fracture.
Yeah, that's right. But this is a little different kind of a problem. This you have to open up.
Yeah. So that, okay.
All right, so this is a 49-year-old with trauma. I'm looking at the distal pole of the scaphoid there. It just looks irregular. 8/24/12. Okay. There is 2 months later. Okay, so now you can see a comminuted fracture along the distal pole of the scaphoid there, and it actually extends partially to the scaphoid waist, I think. And there's some tilt. There's some
significant displacement or deflection of the distal component, which you can see nicely here on the CT scan. So that's not good. Here's the MR.
This is a fracture that Uncle John would give to a hand surgeon.
Yeah.
I don't like to use a microscope when I do surgery.
There's moderate edema throughout the scaphoid. Maybe the proximal pole is relatively normal, somewhat, but again, that might also be pseudo-normalization. So, yeah.
You can see the actual displacement of the distal fragment better on the CT scan because the cortex is really involved. This is what the MR scan looks like, but this is a distal fracture with flexion and instability here. And so this is a comminuted distal scaphoid fracture which needs internal fixation.
Okay, so we have 2 coronals and 1 sagittal image. On the coronal image, there's looks like probably a comminuted fracture of the scaphoid waist. I can see the proximal scaphoid. I don't see the distal fragment very well, so it may be displaced.
So why do I have the sagittal image?
Well, I don't see the scaphoid well on this image, but I think that there may be some. Yeah, I'm not sure.
So this is
Jennifer, it looks comminuted, doesn't it?
yeah, this is an acute fracture, but if you waited a while, what would happen is you'd end up with DC instability. We'll talk about it. I'm not going through the instabilities because we've got a lot to discuss when it comes to the instability, and that'll be later, and I don't want to spend a lot of time now when we've got a much better slides of what DC and BC instability are later. But this is a normal configuration. We'll talk about what's normal and abnormal later of the capitate and lunate, which means this is acute. You haven't yet stretched all the other ligaments around, making it unstable. So presumably you're in a better shape of being able to fix the fracture here, letting it heal, and not going on instability if you treat it right away, rather than waiting until you got the other laxity which goes along with instability here. So this is an acute scaphoid fracture with no DC, but it needs to be stabilized. Okay, Michael.
Okay, so hold on. So on the 2 coronal images, you see some kind of minimal edema in the distal scaphoid and some sclerosis. And on the sagittal image, it looks like we see a defect in the anterior volar aspect of the scaphoid with bony bridging and protuberance. So is this a remote distal scaphoid fracture that like only partially healed with this kind of bony protuberance posteriorly?
Do you know what that bony protuberance is called?
I do not.
It's called a humpback deformity. So this is what happens to the scaphoid if you have a waist fracture. It flexes anteriorly and then heals, and then you end up with a humpback deformity of the scaphoid. This then goes on to DC type instability usually, and can then be chronic hand wrist pain. So that's a humpback deformity.
All right.
All right, so here we have a fracture, an old fracture it looks like, with some sclerosis of the scaphoid waist, although there's a lot of edema there, and there's DC deformity on the sagittals, and yeah, looks pretty extensive.
This is called the snack wrist, which is scaphoid non-union advanced collapse. And what you can see here is a dorsal tilt to the lunate, but you also have some dorsal displacement of the capitate and foreshortening of the wrist, which is the collapse part of this. And as you see, this is a chronic non-union scaphoid waist fracture. So we want to pick these up early. We want to treat them so they heal, so that you don't end up with this. You have a lot of degenerative disease here, and this will typically end up requiring a fusion of the wrist.
I have seen hairline fractures that were not treated for 2 years and then come in with a minor injury and claim that they suffered a fracture of the scaphoid, which looks like it's been there for forever. And the case I'm talking about was in court, it was missed at a university, a hairline fracture, which was quite obvious to yours truly. And the fellow tried to blame it on a minor accident as the cause of the non-union, as being an acute fracture from the injury. In any event, they lost the case, and what the unfortunate thing is, a hairline fracture that you could barely see, literally a hairline, wind up in a wrist that's a real mess. And that's something that you never want to see as a radiologist and miss. And that was missed at a major university here in town. I'm not going to tell you which one. I don't want to do that.
Okay. Right.
But the hairline fractures you miss, you can have a real problem with these. No doubt you're going to wind up in court.
Yeah. Yeah, these are important fractures. This is just a case where you have an old scaphoid waist fracture, humpback deformity, and this also has an extra ossicle here, which is an styloidium. So, and that's what they felt was a bump, hard bump posteriorly, which is called a carpal or a carpal boss, back in there, which is this bony prominence right here, which they were feeling. Here's just another case of a carpal boss, 14-year-olds, where you can see kind of prominence back here from an old injury and a little cystic change there. Yeah, Carpectomy. And the differential here is old trauma, just congenital, but the thing you want to really look for is correlation, because this is commonly associated with correlation. So you have to look to make sure that there's no correlation.
Clinically, these can look like ganglion cysts. And I made a boo-boo, and I tried to treat one by compressing it and tried to break the cyst and as a treatment. It didn't work out too well. Finally, I got an x-ray, and I was very embarrassed when I saw what I saw. I was trying to puncture a bossing. You cannot puncture a bossing, by the way.
Yeah, right. Unless you have a drill.
So, John, you're worried about that possible mistake you made way back when. Don't worry about it.
Yeah. No, the patient did fine. Okay.
No reason to.
Okay, so this is status post-surgery, and I don't see much of a scaphoid or a lunate at all. It seems like it's collapsed and displaced and... Oh, okay.
What do you think that surgery was?
Carpectomy.
Jennifer?
A carpectomy?
Yeah, what do you think that surgery was on that last case?
Probably for severe degenerative disease related to a fracture.
No, I think what that was removal of the proximal row. Am I right, John, or am I wrong?
You're right.
Thank you. That's what I see. You don't see the proximal row of the carpal bones.
Is this usually done for severe degenerative changes or for necrosis and collapse, or what reason would you do it for?
The reason is pain. If it's painful and you cannot fix it in any other way, you can either fuse it or remove the row. This situation, they felt better removing the carpal row proximally.
Michael.
Okay, so 6-year-old male with acute injury to base of the thumb. So on the stir or the fluid sensitive sequence, I see quite a bit of kind of edema fluid surrounding the base of the thumb. On the T1, that sliver right there, I'm trying to figure out if that's like a bony fragment. It looks bright or hyper intense, like it would be a edematous. I don't know if there's like an avulsion injury or ligament. So right here where they're saying see edema in the soft tissue, so I'm concerned that there could be like a ulnar collateral ligament injury or abductor pollicis muscle injury.
Yeah. So.
Or I guess sorry, this is base thumb, so this would be the anterior oblique ligament that could be injured.
This is the anterior oblique. That's right. So as you all know, this is a very, very common location for degenerative disease. You've seen the multiple MRs of the wrist. In this case, we can see a lot of degenerative disease of the capsule, a little bit of an effusion, and in this case, this is an acute injury with probable an acute tear of the anterior oblique ligament, maybe the posterior as well, and this due to probably a dislocation of the base of the thumb. In this case, and we can see that there's some injury to the adjacent muscles as well. We'll talk more about the anatomy around this area in later talks, so I won't go into a lot of detail. We have some diagrams where we'll show the anatomy. And this just shows multiple fractures of the metacarpal bases down here on gradient echo images and T1s. And this patient got frustrated and punched the wall in the wall one.
I don't know if we're looking at the first CMC joint, if there's some degenerative change there. Yeah, and then some spurring. That's a fracture, yeah. Looks like a fracture, actually. Okay, see a fracture of that proximal base of the first metacarpal.
It's got a name. What's the name of it? Starts with a D, I think.
I'm not quite sure.
Isn't that a Bennett's fracture, John? It is.
One of several Bennett's fractures.
The thing about Bennett's is that he got more than one fracture to his name.
Right.
So you better describe what you see.
Right. Good.
We're not talking about the shoulder.
Right.
Okay, so now it looks like we're at the level of the thumb MCP joint, and it looks like the physes may be open. So this is a younger patient, and there's some increased signal kind of along that. I think this is the dorsal capsule of the thumb, so I'm concerned about an injury. I'm not sure if this could be a avulsion or I guess strain injury of the ulnar collateral ligament. First ray fracture.
Stress fracture of the second, and a little corner fracture at the base of the first proximal phalanx. Okay. Michael.
Okay, so there is a either like erosion or subchondral cystic change in that third metacarpal head. MCP dislocation.
This person actually had a dislocation, and this was acute subchondral trabecular bone injury from the dislocation.
I guess it's been replaced, and this would, yeah, you'd be worried about a either subchondral bone injury, even maybe an osteochondral lesion.
Right. All right. Most of the time, when you see this, it's going to be someone who has degenerative disease due to overlying loss of the articular cartilage. But this was someone who was younger and just had an acute dislocation of the metacarpophalangeal joint. and that was a little bit of a acute edema.
All right, looking at the distal aspect of the metacarpal here, looks like there might be a fracture and a joint effusion, and then there's also some subcondylar injury. I don't know if that's, or is that just tubercular injury? It looks like there might be a fracture, but.
So this was another, and you can.
I think I would call it a subluxation. I'm not sure I'd call it a dislocation.
Okay, well, the history was dislocation, and I don't know how far.
Oh, they try to reduce it. This joint doesn't reduce very well. Things get caught in a joint, and the harder you pull, the tighter those things get, the ligaments, that is, and so you have to do an open reduction.
Okay.
To get it back in place. Otherwise, you wind up with a chronic subluxation of the MP joint.
Yeah, and this patient actually had a dorsal capsular rupture as well.
Yeah, that doesn't help either.
Okay.
All right, so here we're looking at the 5th digit PIP joint, and there's a lot of soft tissue edema and increased signal along those radial collateral and ulnar collateral ligaments. So an effusion. I guess this could also be trauma or subluxation.
When you think about other things, this could be infection. This could be the early part of a dactylitis if the patient has psoriatic arthritis. There are other things it could be, but this is pretty typical trauma. And this patient had a typical history of trauma. And you can see a lot of hemorrhage around it and bone edema. Actually, why don't we stop here and we'll talk about osteonecrosis in around the wrist and hand starting tomorrow. Okay? Any questions?
No, thank you.
Thanks.
Well, everybody have a good afternoon.